We will have a lightning speed panel discussion because the only thing between you and lunch is our panel. So come on up, please, everyone. Okay, question?
Dr. Vasan, I was wondering if your program had reasonable data and what kind of numbers you have for necessity of changing over to the optical colonoscopy and how often you're running up against important intra-abdominal and intrapelvic findings.
So about 1 in 300, can you hear? So about 1 in 300 cases, they end up having extracolonic findings which are significant to the patient. We find colorectal cancer, I'm not talking about polyp, but colorectal cancer itself, 1 in 500 cases. But if you want to look at extracolonic findings that are significant, such as cancer, other cancers outside of the colon, it's about 1 in 300 cases. And I'm sorry I didn't get the first part of your question.
How often are you having to convert to an optical colonoscopy?
1 in 10. 1 in 10 cases end up recommending to go on to an optical colonoscopy.
Okay, so a question on the side there.
Two quick questions. One is on the pediatric imaging. I didn't see any interest in just plain X-ray. So that's one question. And adult side, is there any fall guidelines on fatty liver re-imaging?
Yeah, thank you for bringing that up. I did avoid going into the abdominal X-ray. It's a very low risk, low cost study, and I think the yield is also pretty low in most cases.
And to talk about fatty liver disease, that is a really good question that we're studying at UT Southwestern, but there's really no good data to have recommendations on when and how to follow up patients with fatty liver. It is so common. I mean, at Parkland, where I also read, I should say we see probably a fatty liver more often than we see a normal liver. So it's sad, really is. And really, you have to look at other risk factors. What they're seeing now is only about 10% of patients with fatty liver are going to have superimposed inflammation, and only about 10 to 20% of those patients will actually go on to develop fibrosis and cirrhosis. So only 1% of patients with fatty liver, but if you think if 40 or 50% of the population has fatty liver, it's still a lot of patients with cirrhosis. So we really have to look at other risk factors, patients who are also drinkers, patients who also have hepatitis and fatty liver. Those are the patients that are going to be at a much elevated risk for having the superimposed inflammation that puts them at risk for the fibrosis. So your run-of-the-mill patient who may just be obese and have metabolic syndrome and fatty liver, it's probably just like you would any other patient, dietary changes, lifestyle modifications, and we can see regression in the fatty liver disease. But as far as when and how to follow up your run-of-the-mill fatty liver, we're still investigating that.
Jill?
We have one question from Twitter. What about the negative D-dimer? This is for Dr. Blomkalns. If the D-dimer is negative and I drew it without doing the modified Geneva or the other algorithm, then is that something that I can trust? If it's negative, does my patient have a PE? Does my patient have a DVT?
So a negative D-dimer by itself is not particularly useful. It has a negative predictive value of only 78%, which means that it's really best used with a clinical decision rule, and you can decide to either use the single clinical decision rule or the tiered approach. But D-dimer should not be ordered willy-nilly. The patients where it's negative are the patients that have had existing clot for a long time, and it's just like a solid clot, and those patients can very easily have a negative D-dimer.
This question is for Dr. Zeikus. We see a lot of daily chest x-rays ordered on inpatients. Are those beneficial, or can you really wait to repeat that unless the patient is symptomatic?
So that is also another very good question. There's data that's coming out that shows similar to the trends for the routine preoperative chest x-ray, just the routine daily, in-house x-ray is of very little yield. However, do keep in mind if there's a change in clinical status of the patient, that's when it's, that that trend is reversed. So, and that's when you would need to do an X-ray. But just for the routine, if their symptoms are stable or getting better, the data that's coming that those are very, very low yield exams.
We'd be happy for that data to be proliferated. Yes,
One of
please.
the group of patients that are missing colonoscopies is the uninsured patient. Can you comment on the cost comparing colonoscopy versus CTC?
Right. So with colonoscopy, it's going to be upwards of $2,000 usually, and that, it takes the facility charge into account. You have to take anesthesia into account, and then the pathology account as well, because based on how many polyps they remove. So CT colonography is going to be a lot cheaper. I'm estimating it's about $1,200 to $300 that we charge, not that we get reimbursed that amount. I've heard numbers like as low as $250 to $300 is what we actually may get reimbursed. So it is clearly a lot cheaper than what optical colonoscopy would be. But of course, you also, when you do the analysis, you also have to take into account, how many of those patients you may have some extra colonic findings that may then need to be worked up. But again, if you put in realistic assumptions and analyze them, it looks like for a population-based screening that CT colonography would actually do very well.
Okay, question over on that side, thank you.
This is for Dr. Zeikus. For those of us who are not necessarily blessed with getting to refer to our good, efficient UT radiologists and surgeons, how do you, or would you give us any tips as to how to refute those people who want to do the excessive screening tests that may not necessarily be indicated for procedures?
Right. One of the hardest things is always changing ingrained practice patterns, right? So my best advice is just to, for people to become involved, use the resources that are available to you. Use the Choosing Wisely website. Use the articles that are, every recommendation on the Choosing Wisely website will have a list of references, so you'll get the peer-reviewed data that can back you up. And that's really what you have to arm yourself with against, to really change conventions.
And just incidentally, the lectures will be available for all participants, so all references, including in the slides, can be utilized and accessed that way as well. Okay, so there's no more questions. I think Sheila has a couple of announcements before we break for lunch.
Oh, do we have one more question? Can you come to the...
I have a quick question for Dr. Fetzer. So what are the diagnostic code that you use for elastography, like ultrasound of the liver elastography? Because we tried to schedule for a few of our patients for that procedure as outpatient. We tried fatty liver disease, NASH, CF-related liver disease, abnormal liver function, transaminitis, whatever you name, and we were told those diagnosis code does not qualify for patient for that procedure.
Well, it's news to me, so that's something I will definitely look into. I can tell you that I've personally seen many patients come through with diagnosis of fatty liver disease, NASH, cirrhosis, or fibrosis rule out, and those have come through and I believe have been approved and reimbursed. So our office can work with you to figure out where that's breaking down, because we are seeing plenty of patients coming in with fatty liver screening for fibrosis as the indication. For just run-of-the-mill elevated LFTs, I'm not sure that would be reimbursable, because really we're looking at those patients at risk of developing fibrosis. And for patients with acute hepatitis with very high LFTs, you don't want to perform elastography, because that'll actually artificially stiffen the liver and may overestimate the assessment for fibrosis. But we're using it routinely, many times a day. So let us work with you and figure out where that's breaking down.
Like radiology office, not GI office. I think we are coordinator. I work with the lung transplant team.
So it really depends on if you're talking about the shear wave elastography I talked about that we implement in the radiology department, which is part of a complete ultrasound of the liver. So you can't order shear wave elastography alone in radiology. It has to be performed alongside a full assessment of the liver. So we actually need two orders, the ultrasound liver and ultrasound elastography. If you're talking about FibroScan, which is the point of care device, they use a different CPT code, and I'm not aware of what their insurance recommendation requirements are for reimbursement for the point of care device FibroScan, but it's a different CPT code than what we use for shear wave elastography in radiology.
Okay, thank you.